Welcome, everybody. It's really exciting to see so many of you from so many different countries. Today is our 14th webinar in our series pertaining to policy issues that we all grapple with, health financing policy issues and PHC financing policy issues in particular. Today, we are exploring digital technologies, the types and uses of digital technologies that exist, and how and whether they facilitate or disrupt health financing and PHC financing in particular. We are going to explore how to make the most of the opportunities they represent, but also potentially protect against their potential conceptual or implementation challenges. We're very lucky to have a really great set of speakers to guide us through today's discussion from the global level to the countries, and we'll hear more about each country in minutes. To start us off, though, I have the immense pleasure of introducing Dr. Inke Mathauer, who many of you no doubt will already know. Inke is a senior health financing advisor at the World Health Organization in Geneva. Inke has over 25 years of experience working on a wide range of health financing issues, from governance to provider payment mechanisms, and of course, digital technologies and health financing, which Inke has published widely on, not wildly. So Inke is going to share with us the latest global level evidence on what we know of the types and uses of digital technologies for health financing. Inke, over to you.
Well, thank you so much, Nuria, for the nice introduction, and good morning, good afternoon. It's really a pleasure to see so many here and this huge interest in the subject, digital technologies for health financing. So in this introductory and framing presentation, I'd like to give, first of all, an overview of the topic and sketch out the issues at stake so that we are all on the same page, basically, and set the stage for the country presentations as well as for the discussion. So the next slide, please. Let's quickly start with some terminology so that we use and have the same concepts in mind. And I think the most important, first of all, is what are digital technologies? What are digital technologies in health systems and financing? And we can understand this as electronic tools, systems, and devices that generate, store, process, or transmit data. It's a very generic definition across sectors beyond the health sector, but I think it's quite useful if we think of it from this fundamental point of view. Then next, we have to distinguish between digitization on the one hand and digitalization. Digitization is the basic step of converting analog information like paper documents, like a doctor report on paper, into a digital format. And we do find countries actually on quite different stages in this digitization process. If I just take my own country, Germany, it's not a joke. We are starting to actually digitize, doctor reports and put that on an electronic card. So countries are on this stage. And once data is digitized, then digitalization comes in, which is the process of leveraging digital technologies to transform business processes, the business processes related to health financing in our case, with the idea to improve efficiency, create new value, increase revenues, etc. We'll hear more about all those benefits. And then let me just talk finally about digital public infrastructure in health. I think this concept is gaining attention. And it can be understood as a set of foundational interoperable digital systems to support healthcare delivery or health financing in our case. And the three core pillars are digital identity, data exchange, and payment system. And in fact, in the next two country presentations, we'll come back to some of these points. Next slide, please. Here on this slide, I've put together the key or the main types of digital technologies supporting health financing. So The black ones are sort of the types of digital technologies, and the blue ones are examples in health financing. So we start with information management systems. This has been in place since many decades, if I may say so, several decades. You could think of an electronic patient record in a doctor's office. But I think the next real important development is to shift information management systems into web-based databases or platforms that allow for near to or actual real-time data exchange and access anywhere in the country where you are. So then this idea of an electronic patient dossier would make sense. Or in some countries, this is highly relevant, you have a list of members whose health coverage is subsidized. So they are on this specific list and they have a card, and so because they're subsidized, they wouldn't pay contributions. And so having this web-based database is important for anywhere in the country, in a facility, to know what's the status of this patient. Of course, then we have mobile phone applications. We have a lot of, for example, East African countries, but also Asian countries, where there have been enormous developments and advances in this field for enrollment, for registration in a health coverage scheme, or for many other features such as information provision. Likewise, related thereto, we have systems of digital payments or digital wallets, where a person, an individual, can make a payment, for example, to a health insurance scheme. Or we also have examples where actually people can pay taxes through their mobile wallets or digital wallets. Next slide, please. Then we have the very huge field of machine learning and artificial intelligence, which is growing very fast. We have undertaken a literature scoping review to sort of get a sense of what's happening in health financing and machine learning. This is a couple of years ago. I think we published this 2 or 3 years ago, and I would assume that within the last 3 years, many more applications have come up. But I'm just giving here one example, which is the predictive analysis and the identification of future high-cost patients. Can be a good thing, but I'll also put a little question mark, maybe later for the discussion. Another fast evolving field is generative artificial intelligence. I'll just use this very generic terms, but there are different types, of course. This could be used, for example, for automated medical documentation for claims preparation. And last but not least, there is blockchain, which allows for secure, transparent, and immutable transaction records, which could be used for automating insurance claims with smart contracts, or for actually validating pharmaceuticals, etc., etc. Next slide, please. On this slide, there's a quick reminder of our health financing for UHC framework. Next slide, please. And what I really want to illuminate here is where digital technologies come in. In fact, they come in at the level of the health financing functions, or even below that for specific health financing tasks. So here I've been on this slide, you just see 2 per functions, but there are multiple ones, around those different health financing functions. There can be many. Next slide, please. Now, what we have to be aware of is that, in fact, digital technologies, they change how health financing functions or how health financing tasks are undertaken. So they change the business process, and they also change how the different health financing stakeholders actually interact. But whatever that changes, next slide, please, what's fundamental is that the UHC objectives, the intermediate one as well as the final ones, that they remain valid. Now, you would say, of course, that's self-evident. Next slide, please. But in fact, evidence shows that we can have both positive as well as negative effects of digital technologies on health financing, and then ultimately on UHC. In a positive scenario, and we do have evidence of that, of course, and we'll hear from the next 2 country speakers, a digital technology can enhance, simplify, or support a health financing function or a specific task very often, and thus also help inform health financing policy that is conducive to UHC. But on the other hand, we do have examples and we do have evidence where the use of digital technology may also play out in a negative way. because there's inadequate design or inadequate implementation, or because in fact the digital technology for a specific health financing task is not in line with sort of the surrounding digital ecosystem, so there's a disconnect. Or you could also think of an example where in fact a digital technology enhances, simplifies, or supports a health financing mechanism that in itself is not UHC oriented. And I'll just give or not per se UHC oriented, and I'll give quickly the example of private health insurance schemes. In a lot of countries, and I can think of African countries, there's lots of private voluntary micro health insurance schemes, and they're really great in making use of digital technologies to support their registration and their membership function, for example, and hence also the collection of contributions. And so what it does potentially is that it actually affects one of our core health financing desirable principles, which is namely largely and primarily relying on public finance. But as said, if there's this great support for the private health insurance, it sort of unbalances potentially this principle. It's not the fault, of course, of the digital technology itself. The question is really, and what matters is how and for what the digital technology is being used. Next slide, please. So here I am just synthesizing findings from our various country case studies that we have been undertaking on digital technologies for health financing, as well as synthesizing literature. And here we see sort of the main effects, the main positive benefits of using digital technologies. As they contribute to the intermediate as well as to the final UHC objectives. So the most important effect is obviously on efficiency with lower administrative costs, higher process speed, etc. It can also, of course, support and improve access or make access more equitable. And I think we will hear about that in our next presentation. It can also help improving financial protection and, of course, transparency. Related there to trust and accountability. But what I really want to convey here is this point. In fact, the digital technologies, they help overcome challenges that are inherent in paper-based data systems and in manual systems, which is very time-consuming. And at a certain scale, it's simply not possible to undertake it on a manual basis. And as I was mentioning, the digital technologies, when they support web-based platforms, they enable real-time or near real-time data exchanges. And with that, what we have to see and what we have to search for and to seek for is that digital technologies enable otherwise hardly implementable health financing policy options aimed at the final UHC objectives. And so I think there are some great examples and country cases where we have seen that digital technologies unlock new potentials. They do not just support existing health financing tasks, but they actually unlock new features and new thinking. And next slide. But, very important, but there are risks. There are lots of risks and challenges, and they're not unique to health financing. You will find those challenges also in the health sector and even beyond in other sectors. So that's quite interesting. So we need to understand these risks, and we need to understand them very well, because addressing them might then not be a generic approach. We will potentially also need health financing specific solutions to these risks. And again, I think I don't have the time to go through all of them, but I'll just highlight a few. Of course, we are aware of the widening digital divides across populations, but also across healthcare providers. We shouldn't forget, and between the public and the private sector, there is a digital divide. There's the data security, data protection issue. But more important, I think, is the fact that in lots of cases, we have inadequate regulatory provisions, especially for AI and machine learning use. And that's because the technological innovations are faster in speed than actually the regulatory provisions to address them. And that raises a lot of ethical questions then. Last but not least, as I mentioned already, there can be lack of alignment between the digital technology itself, its design and implementation, and then the larger digital ecosystem, which creates disconnects, lots of problems also related to interoperability issues, where we have lack of coordination across different system components. And another related issue there too is, as you may know from your own countries, is sort of this fragmented, is lots of pilot projects. But I'll move to my last slide very quickly. So to conclude, there are a number of essential requirements for steering the digital transformation to be conducive to UHC. And the first one is that there is a clear governance structure, clear functional governance mechanisms, so that governments are actually in the driver's seat to steer the digital transformation rather than being driven, rather than being sort of, guided by other, private sector interests. Of course, we need the private sector in steering this, in driving this, or in supporting this, but it's the government that has to be in the driver's seat. And related thereto is the need to have a national digital health strategy. Often we find that digital technologies are not really captured there, they're not really mentioned, they're sort of overlooked. And so there is a gap. This really needs to be addressed. And what's important is to also be clear, what's the role of digital technologies in health financing and how do they link up with the larger digital public infrastructure in the health sector? I did mention the need for addressing the risks, so we have to be aware of them, anticipate them, and then take policy choices around them, as well as address the regulatory needs to avoid difficult unethical outcomes. And last but not least, governments need to build up capacity in digital technology for health financing. What I mean is capacity also within the public sector, among health facilities, but also within the Ministry of Health itself when it comes to having a regulatory capacity available. And with that, I'll stop and I have now the pleasure, let's have the next slide. I have the pleasure, no, sorry, I just wanted to briefly show a number of our publications. They're not all of them, you will find more on our webpage, but these are the country case studies that we have been undertaking. Thank you so much for your attention. And I have now the huge pleasure to introduce Maarten Oranje. Maarten is a health system and health financing expert, also education expert. He's working with Cordaid, where he is inter alia supporting performance-based financing implementation across multiple African countries. Maarten was a long-term consultant with our health financing team here in Geneva and provided fantastic support and input to our work on digital technologies in health financing. And so over the past couple of years, the two of us, we've been closely working together on a number of pieces, conceptual as well as country studies. And so I'm very, very happy, in fact, to have Maarten here for this webinar for the moderation. And over to you, Maarten. Thank you.
Thank you, Inke. Thank you also for your kind words and for your very comprehensive and enlightening presentation, conceptual presentation on the benefits and risks of digital technologies in health financing. We now turn to our two country presentations. We will have country presentations today on Estonia and on Rwanda. Estonia reformed its co-payment policy and specifically for outpatient medication prescriptions, and it automated the benefit provision at the point of buying medicine. So this is a digital technology that comes in at the level of the benefits design function. After that, we will move to Rwanda, which recently introduced a new digital system called Kwivuza that supports the operations of the community-based health insurance, the CBHI. So this is about member management. This is a digital technology that supports revenue raising, but most notably also the pooling function. So you see here in the visualization how they come in the broader scheme of things. So we will have the two country presentations, and it is my pleasure to now introduce to you the two presenters that you will hear from. The first being Kasekamp from Estonia. Kaija is a health economist at the WHO Barcelona office for health system strengthening, where she supports governments and also purchasing agencies across Europe and Central Asia. And Kaija previously worked at the Ministry of Social Affairs in Estonia and also at the Estonian Health Insurance Fund, the EHIF. After that, we will immediately turn to Rwanda, to Ina Kalisa. Ina is the head of the community-based health insurance department at the Rwanda Social Security Board, and she previously worked at the WHO Rwanda as a health economist and also as a lecturer and researcher at the University of Rwanda, the School of Public Health. But first, the floor is to you, Kaija.
Thank you, Maarten, for the introduction, and welcome everyone to this webinar. So to start with, Estonia is a very small country, maybe a country that some of you have never heard of, but it's kind of famous for its different digital solutions. So we file taxes online, we vote online, and yes, we even try to better protect patients from high medicine costs, if you can say so, online. So today I will show you how the Estonia turned the small IT innovation into something much bigger. A system that automatically protects people from high costs related to prescription medicines without extra paperwork or without extra waiting for people. You can read about this in detail in the referred report, which we published early this year together with Inke and Maarten and with my dear colleague Trine Habicht. The story that I will present today is a summary of the policy reform, and it covers how digital technologies can turn good policy intention into improved access for patients. And it can do so quietly, efficiently, and equitably. So how it all started for us. In line with the principles of the Tallinn Charter, Estonia's health policy has consistently emphasized that individuals and families should not become impoverished as a consequence of ill health or use of health services. For ensuring this, we need to monitor financial protection, and Estonia has probably one of the longest standing traditions of monitoring financial protection as a part of its progress towards UHC, universal health coverage. The data from the UHC watch produced by the WHO Barcelona office shows that the risk of impoverishment due to out-of-pocket payments for health services has remained a big concern in the country. When we dig deeper into the data, we do see that households facing catastrophic health spending for health services were mainly affected by the high cost of medicines and particularly prescription medicines. So this evidence was a starting point for our reform, which we did implement in 2018, and with what my presentation now will mostly cover. In many countries, as well as also in Estonia, we do apply percentage and fixed co-payments for covered outpatient prescription medicines. We do have some reductions and exceptions applied depending on the medicines group or person's characteristics. For example, the co-payments are small children are exempt of co-payments, as well as there are exemptions for some life-threatening health conditions. But despite of these exemptions, for some population groups, for example, patients with chronic conditions or patients receiving very costly care, these heavy these heavy uses of the prescription medicines, the co-payments can still add up to be a significant financial burden. So this prompted us to the question, how can we improve the financial protection for these people? Already since the early 2000s, the insurance fund had introduced a system called the additional medicines benefit. So we call it on a national level like this, which is basically a system that accumulates person's percentage co-payments during a year. And if these co-payments exceed a certain amount, then the co-payments are further reduced. So for example, if your annual co-payment for your prescription medicines exceeds 300 euros, then for every additional co-payment that you would have, the insurance fund covers additional 50%. And if your annual co-payment exceeds 500 euros in a year, the insurance fund covers additional 90% for the patient. So despite of these reimbursement rules existing already since early 2000s, and we had the digitized data available at that time to make these estimates, it was required that people would apply for the benefit. And people needed to be aware that this system exists, and it appeared that not many people actually knew about it. So it was kind of a lost opportunity. There was a benefit in place, but people were not aware, or they had challenges to apply for it, thus they could not use it. And furthermore, even when you were eligible and you knew how to apply for the benefit was retrospective. So you got your compensation afterwards when you had made an application from the insurance fund, and you could not use it at the point of purchasing the medicine. So with the reform introduced in 2018, the process was changed completely thanks to digital technologies. With strong political commitment and additional public funding, we reformed the system and reduced the annual spending thresholds. So you can see from the slides, from 300 to 100 euros a year, and from 500 to 300 euros a year. But this was not the most important part of the reform. The most important part for this reform was the use of digital developments. So in parallel, a digital technology was developed which tracks a person's accumulative annual spending on medicines in real time. So once an individual reaches the defined spending threshold, the additional medicine benefit is applied immediately, reducing their co-payment at the point of purchase. So patients no longer needed to submit application or even be aware of the benefit. The system ensures protection as soon as eligibility is met. Of course, to implement such a system, certain preconditions and enablers needed to be in place. So as I mentioned, Estonia is well and widely known for its vast use of digital technology. There's high digital literacy in the country. Also, we had the data digitized already. So all of the prescription data was digitized since the early 2000s, and we had the e-prescription system in place starting from 2010. Furthermore, we had introduced interoperable information system to link example for insurance database with population registry and data provided by the pharmacies. Beyond technology, this reform also required a shift in the mindset, from seeing financial protection as something people must claim to something that people automatically receive as a part of the right to receive care. As most importantly, strong political commitment also needed to be there. And as I mentioned, we were lucky enough to have the opportunity to use this political window of opportunity to implement this reform. So how does the system actually work? So when a person visits a doctor and receives an e-prescription, the prescription is automatically linked to their unique ID within the insurance fund database. So every time that person purchases a medicine at the pharmacy medical information system sends the information to e-prescription database, and the system records the amount of the co-payment and adds it to the accumulative annual total. So the process of identifying the co-payment level by the e-prescription database is described in these 9 steps, including checking insurance status, the covered medicine reference price, co-payment level depending on the medicine's type or patient characteristic. But all of this was there in the e-prescription database already before the reforms, or starting from 2010, with an exception of the points depicted on step 6 and 7, which was the new design of introducing a digital technology, also accounting for the additional medicine benefit. Thus, the new development, the e-prescription system, calculates the accumulated co-payment amount now for the patient and defines eligibility for the additional medicine benefit, and then sends the data immediately to the pharmacy, and the pharmacy would get to know what is the amount that the patient needs to pay. From the pharmacist's perspective, the process is seamless. The insurance fund's digital system calculates the correct co-payment amount in real time, and the patient only pays accounting for the reduced amount. So reimbursement to pharmacies is handled automatically through the same electronic interface. And for this, minimal updates were required: automatic monitoring of accumulated co-payments, enabling real-time data exchange. And I put here an example also how patient transparency can be increased. Next slide summarizes the impact of the reform. From the patient perspective, we see that the automation process made it happen that when prior to the reform, only 37% of the people who were eligible to the benefit actually received the benefit, then with automation, it reached up to 100. So this was an immediate impact. And we do see that year by year, also the number of people benefiting from the reform do increase. In terms of the impact from the system perspective, on the next slide, we will see that we do see with this reform that the digital technologies can operationalize equity-oriented policies with minimal burden to implementing agencies, because this reform was actually not costly at all. It cost the fund only 50,000 euros in 2017 with the development. Although the insurance fund has to remain some level of IT capacity, the cost was just marginal compared to the impact it had for the population. And to sum up, over the past 2 decades, Estonia has consistently pursued a vision of people-centered, digitally enabled health system. And exactly as Inke also summarized, our experience shows that digital tools are most powerful when combined with sound governance, clear accountability, consistent capacity building, and sustained policy commitment. And in parallel, it's also crucial for policymakers to find the ways for leapfrogging, ensuring that there's right sequencing and having policies ready to be used during windows of opportunity. Thank you so much, and thank you for the patience staying with me. I hand over back to you, Maarten.
Thank you so much, Kaija. That's for a wonderful presentation on Estonia. We will now immediately continue with the presentation from Rwanda. So the floor is yours, Ina.
Thank you, Maarten. Good afternoon to you all. It's a joy to be with you today to share the CBHI experience on how digital innovation actually strengthen the health financing functions of the scheme by giving the example of Kwivuza. So before that, I would like to give a small background on Rwanda. Our population is approximately 14 million population. 90% of the population is covered by some form of health insurance, but the CBHI in particular targets the informal sector and covers 82% of the population. The scheme is financed through a different mix of funds, including contribution from households according to their socioeconomic status, and this constitutes 33% of the revenue of the scheme. The most vulnerable are fully covered by the government for premium payment, as well as exemptions at the point of care. So RSSB, which actually manage CBHI, has a vision of becoming a data-driven and evidence-based organization. And this can only be possible by investing in infrastructure and technology to enable access to timely data. And so it is in this context that Kwivuza was developed, and it means literally to receive medical treatment. So Kwivuza is an online platform that simplifies member registration and medical claims processing while allowing generation of actionable data. But today's presentation will only focus on the member management. So CBHI digitalization journey started in 2018 with 3MS, which was launched for member registration and eligibility checks, which later included or integrated mobile payments, which contributed to boosting enrollment. In March 2022, Kwivuza was developed in-house by RSSB, starting by the membership management side, and replaced 3MS due to ongoing technical challenges. So in April 2023, a real-time claim management module was added to Kwivuza. The digital features of Kwivuza includes that the platform is built with scalable microservices, which mean that it's actually small and independent components that can grow or change depending on the needs without affecting the whole system. It's a web-based platform with a bilingual interface, meaning Kinyarwanda and English, and it can work both on computers and on phones. It allows real-time data exchange and automated data checks. So, for example, you can check or verify a national ID of the members. We have auto-registration of life events like death and birth due to integration that we have with other systems. And it's in terms of its security, it allows for multi-factor authentication, including one-time passwords, and it's a role-based access control. Kwivuza supports actually many health financing tasks, but today I'm focusing on its capacity to improve our revenue collection and funding pool. So today it's really easy and faster for our members to register and renew their membership. You don't have to come to CBHI offices and queue to have your card validated as we used to have. So you can check your premium that you have to pay according to your socioeconomic category and the number of people in your household. You can pay using a convenient payment channel, and the scheme has become cashless since then. We can easily monitor coverage across the country and the payment compliance. So this is the Kwivuza platform. That's the clinic view. This is the view that the clinic will have when they want to check the patient eligibility. So you would, if you have a facility, you will have to enter your phone number and dial a USSD code and receive a one-time passcode and enter into our system, be able to check eligibility of the patient, and you'll see the detail about the household. When you have their NID, you can check if the member is a government supported or if the member has to pay. And this is because when you're a government supported member, you don't have to pay at the point of care. So you can also see who are the household member of this specific household. You can see their contribution and so forth. But our member can also check if they're eligible using a USSD code, as you see displayed there. So before I take you through the process of how members pay their contribution using the Kwivuza system, I'd like to mention that Kwivuza is actually integrated with the Dynamic Social Registry, which is a database managed by the Ministry of Local Government. And this database collects information about household, including, the names of the household member, the age, the gender. It also collects information about the welfare and socioeconomic status of the members. And this supports actually targeting for social protection programs. And so we leverage on that database, which is also integrated with the civil registration and vital statistics, which records life events such as birth and death. And the same database is also connected with the National Identification Agency. And this actually enabled the NID verification. So when a member wants to pay or be enrolled in the scheme, the household head will have his national ID and will use a USSD code to check in the social registry whether the information of his household or her household is complete, meaning the names of the member, the number, because the premium is paid based on your socioeconomic category, but also the number of people in your household. So when the information is correct, you can proceed with paying. When your information is not correct, you'll have to go to administrative cell for correction. So if your information is now correct, a member can pay using different payment channels, including mobile operators like MTN, and also one of the government platform that offers, it's an online platform that gives different public services. And so this allows our member to actually pay, and automatically when you've paid, your payment is recorded and you're now eligible. So as a member, you can check that you're eligible using the NID, and even the health facility are now, so the health facility electronic medical record is also integrated with Kwivuza, but for eligibility checking using NID as well. So this integration with the two database actually simplified premium payments and improved the efficiency of the collection of revenue by the scheme and strengthening its financial sustainability, while also removing the need for facilities to verify eligibility through our system. The first graph is showing you how coverage has increased over time, and how the introduction of technology for premium collection has contributed to increasing the coverage and remove the need to come and queue at our offices at the centralized level. Then the graph on your right is actually showing you the contribution by payment channel. And so members pay their contribution using the most convenient digital platform that they have available, making the scheme completely cashless. So in terms of the lesson learned for our scheme, RSSP is really committed to making this motto, zero paper, zero trip, a reality for our members. And it actually required strong stakeholder or collaboration, especially for integration with other databases. Of course, we have ecosystem that actually enabled RSSP to move in this digital transformation. So investment in digital infrastructure and connectivity, the different policy and regulation and governance framework available, the availability of public services that are digitalized as well. And of course, we can't forget that having an in-house digital team facilitated this national scale-up of Kwivuza. So basically what it allowed us to do, it has allowed us to move faster than when we used a vendor approach, which also allowed iterative development as feedback will come from the users. And so we also are cognizant that you need to sequence the rollout to reduce risk and allow learning before full scale up. So yes, Kwivuza was actually tested in a few facilities for 3 months before rolling out. Kwivuza tomorrow will drive and continue driving continuous improvement and innovation. We intend shortly to also launch a biometric facial recognition, optimize the premium subsidies and exemption by so the dynamic social registry will actually integrate with other government systems, like if you have a land, it's actually recorded in the land center. If you earn a salary, then we'll have that information and be able to set our premium more effectively. And then I think I'll stop here. The rest you can read for yourself. Thank you so much for your kind attention.
Thank you so much to you, Ina, and also to Kaija, for 2 very insightful presentations on these country examples from Estonia and Rwanda. We now turn to Ethiopia, and we turn to Girmaye Dinsa, and he will share first his reflections. He is our discussant today his reflections on all three presentations that we've seen so far, so the two country presentations and also the conceptual presentation of Inke. Girmaye is a health financing advisor to the Minister of Health in Ethiopia, and he also serves as the Deputy Director for Health Financing at the FENOT project at the Harvard Chan School of Public Health. Before that, he was a research fellow at the London School of Hygiene and Tropical Medicine. Girmaye, please go ahead.
Thank you, Maarten. Thank you for the opportunity to serve as a discussant. So let me start with the country presentations and do a couple of reflections. Regarding Estonia, as you have heard, Estonia's experience highlights the value of gradual capacity building approach to digital technologies implementation. This incremental strategy has enabled Estonia for learning, adaptation, and I think sustainable scaling of digital solutions. In fact, in Estonia, some policies, particularly the policies around providing benefits at the point of purchase, have been made possible only through the digital application of digital technologies. And particularly the country's strong human capacity base and the pre-existing digital infrastructure have also contributed to reducing the cost of the digital technologies implementation and its maintenance. So Estonia's experience underscores that digital technologies can enhance equity and efficiency within programs. Conversely, if there are underlying disparities in access to technology that could potentially exacerbate an already existing inequality, if particularly we are not deliberately addressing through inclusive design implementation measures. So that's a quick summary of the experience from Estonia. If I quickly move to the case of Rwanda, the case of Rwanda demonstrates that significant progress in building a cohesive digital ecosystem with strong linkage across databases and almost near real-time data exchange was a very good experience from Rwanda. It shows that the interoperability is largely dependent on the governance-related decisions, which means interoperability is not really about technical matters. It could be also a governance matters, requiring commitment on data sharing and alignment of authority from the governance system. So it's not really a purely technical issue. And from Rwanda's experience, again, I think the use of the USSD system, which does not require sophisticated technologies or does not require smartphones, for example, or advanced technology, that has showed or that has enhanced the accessibility and inclusiveness of the system, making the digital solutions viable even in low-income settings like Rwanda or Ethiopia for that matter. So, and Rwanda also showed that digital technologies have also facilitated some last-mile service delivery by enabling contribution collection through multiple channels. More importantly, the case of Rwanda demonstrates that using biometric verification, integration with the EMR or electronic medical records, and the interoperability with other government systems have strengthened efficiency and accountability. So if I add a couple of points as a general reflection, the first one is really national ownership and leadership is critical. I think this was also reflected in Inke's presentation at the beginning. So strong national ownership is fundamental to the digital technology. Even when in-house development or development by the national authority is not pursued or required, the active participation of national agencies and institutions is essential to ensure contextual relevance, sustainability of the system, and alignment with national priorities and policies. I think in terms of the general reflection, the second point I would like to emphasize is strategic sequencing and comprehensive planning is important. Implementation of effective digital technologies requires a clearly defined strategy and well-considered sequencing of activities before we start even implementation. Fragmented initiatives and excessive piloting tend to dilute efforts and resources. I can take an example from my own country, Ethiopia, where several digital technology initiatives come through donor funding and NGO projects without necessarily getting integrated into the national or a planned national framework. And when the donor resources and the NGO projects fade out, these digital technologies projects tend to also fade out. And that shows that a comprehensive pathway-oriented approach is critical to ensure coherence and continuity across interventions. And the third and the last point I would like to emphasize is we need to be mindful of digital divide, trust, and literacy. Again, Inke has touched upon this point. The digital divide, particularly the levels of digital literacy among the communities and population, and the issue of trust among health managers, health workers, and communities warrant careful attention while designing digital technologies. So carefully addressing these factors is vital to ensure inclusiveness and effective utilization of digital solutions. Thank you so much.
Thank you so much, Girmaye, for these great reflections to the different presentations. And with that, we now turn to the audience and to the questions that you've been asking in the Q&A. And please do continue asking any additional questions that you may have. But for the questions that we've received so far, I'm turning to Nuria to give us an impression of what people are curious about.
Thank you so much, Maarten, and thank you so much for all the fantastic questions you are posing and you have been posing so far. There's many. So Maarten, I will feed you a first host of questions and then maybe we can come back to a few more. So firstly, there's a question around the clarification of whether human resources for health information systems are or can be integrated within these digital tools that we're talking about, because we know that HR are a very significant part of health budgets. So should we integrate the human resources within those? Then there's questions around the difficulty of implementing those digital technologies in countries with very low internet availability, with low computer availability. We've heard from the different countries that you're using all sorts of systems, but is it feasible, and how in countries with very limited internet availability? Then there's questions around equity, and this is related to the problem with internet availability. Is equity being considered in these tools, and if so, how? And maybe the last question I will pose in this round is, what are the government requirements to be able to implement those systems of digital technology, specifically to reduce out-of-pocket? There's plenty more, but maybe we start with those, Maarten, and then I'll come back to the rest.
Thank you so much. Yeah, these are great questions already. I would like to give all of the speakers the opportunity to respond to these questions. Maybe we do it in the order of the presentations. Inke, would you like to comment on some of these questions? For instance, the first question about human resources, should that be integrated into let's say, the IT plan or the digital technology introduction? But also maybe the last question about governance requirements. Would you like to say something about those?
Well, thank you. Thank you so much for these really great questions. Maybe not so easy answers, but let's try. With respect to the first one, integrating human resources into digital system, absolutely. I mean, this digitalization is taking place in all of the building blocks of a health system, not just in health financing. And I would actually say in health financing, you know, I'm not saying health financing is behind in this digitalization process, but it's certainly not belonging to those building block service delivery, I think primarily, which are quite advanced. So each health system building blocks should ideally get digitalized, first digitized and then digitalized. But it's not just digitalization within a building block. Of course, there is need to integrate the systems to make them interoperable across the different areas. So human resources, supply side management, logistics, health financing. I'm now not an expert on human resource digital technologies, but I mean, I can think of course, it starts with information management systems. It continues with the web-based platforms. I know that mobile phone technologies are an important aspect of training for health workers or for human resource questions. So I think it's a huge area. But what's important is that there is this interconnectivity between health financing and human resources for sure. So great, thank you for pointing this out. Maybe I can quickly reflect on the last question, these governance requirements. I think there were several questions, and in fact, with your question, you actually point out that this is one of the fundamental elements in digital transformation. It's not so much about technical, like IT knowledge. Of course, that's required, and of course there is need to build up capacities and recruit staff in that area. But I think the fundamental issues are governance related. So as I was saying, it's about having a clear strategy, a roadmap. Where do we want to go? Where does the country want to go? Where to start? One has to think about what's the entry point. Do we start maybe with a claims management system and digitalizing it, or is it, so we're talking about, let's say, a health system where we have a health coverage scheme, explicit health coverage scheme, like a health insurance, or do we start on the beneficiary side, on the beneficiary management side, or can both be done at the same time? So thinking about the entry points, thinking about the sequencing, and also thinking about, I think we haven't yet mentioned it in our presentations, about the size of the leapfrogging. Because countries do not have to repeat and go back to what other countries have done 10 years ago, right? I mean, if I may say, in Estonia, we looked at this digital claims management 20 years ago. The process started with diskettes. I think you called them disks, floppy drives and disk, or whatever this was called. So I still have worked with that. But I mean, that's over. So there's leapfrogging. Now you start at a completely different point. But thinking this through, how is it actually connected and aligned with the existing digital public infrastructure? There was one question also, which is really, you know, the hardware, the software availability, the capacity, the digital literacy, plus, of course, the connectivity, the internet and the mobile phone connectivity. If that's weak or not available in rural areas for rural facilities, then obviously it's difficult to move forward with digitalization on specific aspects. So that all comes together. But I think the governance mechanisms and a clear strategy is the starting point and the most important feature to move forward. I'll stop here. Thank you.
Thank you so much, Inke. Maybe Kaija, would you like to add to these two questions, but more from the country, from the practical experience in Estonia? How did you integrate, let's say, the HR component of these kind of innovations? Was that integrated into the broader plan? But also these governance requirements that Inke was just talking about. What did that look like in your country context? I think the question about internet connectivity, I'm not sure if that's so applicable for Estonia, but maybe to the other two questions you could also speak.
Thank you, Maarten. For me, this HR aspect has two sides. So one of them is improving the digital literacy of the healthcare workers, which has been something that we have been emphasizing in Estonia from the scratch. So meaning that if you want to be contracted by the purchasing agency as a provider, as a medical professional, you need to submit your data digitally, otherwise you will not get funded, right? So this was the start in the early 2000s. It was even for us a big push, let's say, for every family physician or for every pharmacy to do this, right? But again, for the countries, this is now, the world is different, right? So we went from this system of submitting data firstly on floppy disks, having them digitized, then sharing the data over secure data e-challenge, but now going to the system of having basically an online data exchange, which is like pretty much a common practice right now, where countries should actually look for as the best solution. On the second side of this HR is having actually capacity in purchasing agencies to do these digital solutions and maintain these digital solutions. And this is something that I touched upon in my presentation as well, because behind our success story, I would say, is one of the factors that we have been able to allocate a decent share of the purchasing agency budget to fund quite costly capacity in the fund itself to maintain such high-level data systems. So this has been like a lesson learned from us, and we still prioritize it up to the day. In terms of governance or government processes of using digital technologies in health in Estonia. So since it has been always on high political agenda in our country, we do have an e-health strategy, which defines clearly our political priorities for developing the systems. So this is as one point which other countries can look for and seek whether they find something to learn from this and developing the separate strategies for e-health development. And on the equity part, on internet access, I quite agree, although today I also work in countries where there are sometimes challenges with internet access, for example, in Ukraine case, and you need to do extraordinary means in order to submit exactly your e-health records, what you would have to submit and find for internet connections. So it's definitely a challenge in terms of equity. But when we talk about specifically in equity terms for this policy reform that we implemented, then in this case we increased equity, because priorly we required patients to apply digitally for the benefit, which many elderly people were possibly not able to do. And probably these elderly people were the ones who actually, having most of the cost related to medicines, but having this system applied immediately at the pharmacy and making the people benefit at the pharmacy, it actually significantly increased the equity in access to this specific benefit. But I will stop here.
Yeah. Thank you so much. On this question of equity, I would like to turn also, because you gave a good example already from how it worked out positively in Estonia. I'd like to turn to Ina, because we have these questions from the audience about the difficulty of implementing technologies in case of low internet connectivity, and also the implications of those digital devices for equity. I'm sure these are things that you have had to think about also in Rwanda, having differences in connectivity between different parts of the country. And has it had implications for how it was implemented in different parts?
Yeah, thank you. Thank you, Maarten. First, I think I would like to tell those who do not know that the scheme is 25 years old. I mean, from the start of the piloting to to today is 25 years, right? And when you look at when we started actually, digitalizing our processes, it started in 2018. And this is because There were several steps, and we've taken advantage of actually high commitment reflected by the investment in digital infrastructure, so internet connectivity, broadband access. If you look at, I was reading recently the mobile phone penetration in Rwanda, and 82% of the population has at least one mobile phone. Not all smartphone, and that's why today we did not build our system based on only those who possess a smartphone. That's why you see we have, even a household with a feature phone can actually, easily access our service. But in addition to that, I think we are also leveraging on our mobile phone operators. They have agents, even the eRainbow platform, which is a government online platform to obtain many of the services that the government offers or the administration offers. They have many agents actually posted in across the country and near to the population. So even if you don't have a phone, you can still, use that agent to facilitate your payment. So I guess it's all about a vision of ensuring that across the sectors, there's this move of digitizing different government services, in particular for CBHI, because we are using, the social registry, which actually collects information that we need to be able to set a premium that goes with the socioeconomic category of our members. So I guess Kwivuza is a web platform because internet is widely available across the country, and perhaps could be a limitation probably for countries where the internet is not as widespread as in Rwanda. But I think it's all about first of all, the vision that you need to start building over time. And like I said, we could not have done it if we were only RSSB. We are benefiting from the digitalization of payment system, for example. I think it's all across many sectors, and we are leveraging on all that to have a platform today that can allow you to easily pay depending on where you are. I think that's what I can maybe say in addition to my presentation. Yeah, and maybe just to say that a health center, we have about more than 1,000 health facilities that we contract. And these are primary care facilities, all of them. And they are all connected. They all have at least one computer to be able to access our platform. So just to say that it's not a big investment, at least for now. Yeah, over to you.
Thank you, Ina. I think that tells us also something about the equity considerations that you've had in introducing this new digital system, Kwivuza. Finally, turning to Girmaye, and maybe also from the perspective of Ethiopia, these issues around internet connectivity, around digital divides. Well, I know a little bit myself also about Ethiopia. I'm sure they are very relevant in the country. Having heard the experiences from Estonia, and especially also from Rwanda, are there any lessons that you think could be particularly relevant for Ethiopia, which is a country that also has a CBHI scheme that also covers a large share of the informal population already, and that is currently at the early stages of a digitalization journey? What are the lessons that you're taking from what our colleagues are telling us?
I think the issue of internet and infrastructure in general is very relevant to the case of Ethiopia. As I said in my discussion points, I think Rwanda and Estonia had the advantage of advanced infrastructure in terms of internet, and also the government focusing on advancing these technologies in general. In Ethiopia, we have started that. But so far, the issue of connectivity is an issue. And I think let's not forget Ethiopia is a very large, diverse, and relatively complex country, even relative to Rwanda. And it's about 120, 130 million population, and a large, geographically large country. And so expanding this infrastructure, internet connectivity, and so on requires a substantial amount of resource and planning. So that has been an issue. And you can imagine if a facility wants to introduce digital technology, at the beginning, they have to record things electronically as well as paper-based, just to make sure that they kind of input the data at a later stage where there is access to internet and so on. So in a way, it can also create burden at the beginning of digitalization. So that's an issue in Ethiopia. But as I said, the government has already started planning, digitalizing the rest of government, like the whole government. And hopefully 5-10 years from now on, that digitalization will advance in Ethiopia. And I think the health sector will benefit out of that, and health financing will also benefit out of that. But at this stage, all those questions in terms of the equity of access to a digital system, the infrastructure, lack of internet connection, and so on is very relevant to Ethiopia. And then I'm sure it's relevant to large countries like Ethiopia in low resource settings.
Thank you, Girmaye. And I think indeed it's also good that you remind us of the size of Ethiopia. If we talk about these different countries, Rwanda has 10 times the population of Estonia, but then Ethiopia has 10 times the population of Rwanda. So it's 100 times the population of Estonia. So this whole digital transformation journey, has different implications probably at a country of that size. Nuria, I'm sure in the meantime, we've had a lot more questions from the audience.
We have had indeed, and I'll again try to organize them into different themes. And I'll put 4 to you to organize as you see fit. Firstly, there is this, we've heard from Ina that it took you 25 years to develop from pilot to full implementation of your system. So there is this tension between leapfrogging, which Inke, you've mentioned and comes through the questions. Is it possible for other countries to leapfrog from these experiences that were presented today? And the tension between that and developing your own system. And we would like a representative from countries to comment a little bit on the time it took them, the cost, both in terms of human resources and financial cost of implementing your own system, and whether or not there was a push to rather leapfrog from what other countries had done. So that's the first theme. The second is a lot of people would like to know whether the systems that you have set up include the public and the private providers. So yeah, that's the second theme. Then there is the question around fraud and moral hazard and supply-induced demand. How do those digital technologies allow you to overcome these issues related to fraud in particular? And finally, questions around the use potentially and the integration of these systems with the unique social registry. We've heard a little bit about it, but participants would like to know more on the question of integration with the unique social registry.
Thank you, Nuria. Ina, let me start with you. I think there are a few questions that I think you can speak to. So the tension between leapfrogging and at the same time respecting the time frame that it requires in a country or the own journey of any country. The question about public and private providers, are they both covered? And then also I think the last question about integration with the dynamic social registry is something that you could probably say a few words about.
Thank you, Maarten. I want to clarify that the 25 years is, the time it took us to have a national CBHI scheme, because it started as a pilot in 1999 and then progressed until the scheme that you see today. In terms of how long it took us to develop Kwivuza itself, it's 2 years, right? In terms of whether the public and the private providers are included, Kwivuza for CBHI is currently available for all primary healthcare facilities. And if you look at the facilities that are available in the country, we have the lowest level, which is a health post. And the health post is a public and private partnership framework where a private nurse operates actually the health post. And so they are all actually, they all use the Kwivuza system. In terms of the integration with the social registry, I'm not so sure I understand the question, but CBHI by design is a scheme that looks at the vulnerable population. And so the only way to cater for the vulnerable is to and actually target those who will receive subsidized premium is to have information about the population. And we do not collect our own household information, so we had to leverage on the social registry, which is managed by the Ministry of Local Government in charge of social protection. So they have a database that we are leveraging on, meaning that that's the interface that our member start with to pay the CBHI premium. I think that's all. Yeah, over to you.
Thank you, Ina. Maybe then Kaija, if you could also briefly comment, and let's try to be brief because we are getting towards the end of the webinar, on the question, are you covering the public and the private providers? In this case, I would think pharmacies, and the question of leapfrogging and the tension that people asked about.
So on the public and private providers, for us, it actually doesn't matter. So if you are a licensed healthcare provider, you need to submit data to the national e-health system. And if you want to be contracted by the National Health Insurance Fund as well, independent whether you are a public or a private provider, you would need to submit necessary data non-dependent of the ownership type, and you get the contracts only if you meet the requirements that the purchasing agency has. So for us, it doesn't matter of the ownership type. Everyone has the same rules in terms of reporting data and providing the benefits. In our case, the pharmacy market is mostly private. In terms of the leapfrogging, and thank you, I think it was Joe who initiated the question. So in Estonia has been kind of the frontier in some of these reform. When we talk about, let's say, the e-prescription system, and it's difficult for me to say like whether we would have used anything, any examples from other countries, because we were a kind of a bit of a front runner on this one. So Estonia has mostly developed all the systems for themselves and less used like opportunities to import certain parts or technologies from elsewhere. This has been our advantage in the system, having very good digital infrastructure and capacity in the country to do our own things. Just to keep short, I will stop here.
Thank you, Kaija. Then we're left with the question about fraud and moral hazard, and whether the introduction of such digital technologies may have any implications in that domain. Inke or Girmaye, would you like to comment on that final question? Do you have any thoughts about it that you would like to share with us?
Yes, I can try briefly. So indeed, fraud is an issue that lots of countries with sort of more explicit or separate purchasing agencies are struggling with once they move away or introduce, let's say, additional payment methods, output-oriented payment methods, so moving away from budget allocations, then this fraud issue comes in. And I think I'm sorry to refer so many times to health insurance or national health insurance, but I think it is in these agencies that we see lots of advances and developments going on. So yes, indeed, digital technology allows for much more efficient fraud detection compared to paper-based. It's obvious because, as I was saying, if you have to go through paper-based claims and piles, it's very time-consuming. It's very human resource intense. And once this is being automated, then obviously you scale it up. So there is huge potential. We also actually looked into the Philippine experience, which tried to introduce a machine learning based fraud detection models, sort of accompanying the existing digital mechanisms for fraud detection. And also, there's lots of research, interestingly, lots of machine learning papers looking indeed at fraud detection, because obviously it's sort of a playing field. There is claims data available, and so models can be tried out and tested against each other. When it comes to supplier-induced demand, another big issue, obviously not necessarily fraud per se, but not desirable either. Again, digital technologies will allow to better monitor what is happening. I think in Estonia, this is a very good case, or Korea as well. There's really sort of a more transparent insight into what providers are doing. You can compare, you can set, you can have benchmarks and then set provider activity, provider behavior against those benchmarks, and then see, is the supplier-induced demand, where is the facility? So there's huge potential. If you allow me, can I say one sentence on leapfrogging, if that's okay?
Yes, please.
Yeah. Because the question was, what can other countries learn in terms of leapfrogging and taking experiences from already advanced, more advanced countries? So Estonia, it introduced the additional medicine benefits in 2003, but only in 2008 was it actually turned around from a retrospective benefit for which you had applied to an automated one that was provided at the point of purchase. And I think as we discussed this and we did the study together, the question came up, interesting, but Estonia would have been in the position to do this turning around already much earlier. The data was there, the technology was there. It was just not introduced as a process, as a business process, right? And so I think this is what countries maybe can learn from Estonia. There are these, once you have the data, think wide, think about the options that are there. Like, for example, Rwanda is probably in the position with Kwibuza to do that. The data is there, the interoperability issues have been solved, so potentially this could be done. And so I think, yes, there is really potential to think about this leapfrogging, but it has to be thought through for each and every country. But I'll stop here. Thank you.
Thank you, Inke. I think with that, looking at the clock, I think we need to start wrapping up. So I would like to thank our four fantastic speakers today, who focused both on the conceptual issues that are at stake and also really at the country level experiences with the very concrete examples. Wrapping up a few things that will stay with me, some takeaway messages. What I really took is the importance, both in Estonia and in Rwanda, of in-house, high-level IT capacity at the purchasing agency. So not being dependent only on private firms, on outsourcing, on external partners, but really having the in-house capacity, which is then closely linked, I think, to the issue and to the term that Inke introduced, a public digital infrastructure, having that entire digital ecosystem in which the digital technologies for health financing will function. And I think what I really took from all that you've said is that there is a certain path dependence. So this idea that certain decisions in the past, they can really either narrow or broaden our range of opportunities in the present. So the sequence in which you introduce digital innovations really matters. Once you've invested a lot of money into a certain technology, yeah, that will probably be with you for quite some time. And your next steps in the whole digitalization journey, they will be determined by the first building blocks of the system that you've put in place. And I think reflecting that's something that's particularly relevant for resource constrained settings. If you have only so little budget that you can use, it's really important to have a very careful decision. Where do you start with this digitalization, and what could be the next steps coming after that? With that, I want to thank all of you, the entire audience, for your attention, for your great questions and your contributions. Most importantly, I'm thanking once again our 4 speakers for sharing their knowledge, for sharing their insights. And for the final few words, I'm now turning back to Nuria.
Thank you so much, Maarten, to you as well for an excellent moderation. This concludes this particular webinar. We have more webinars coming. With this, I thank you all very much for your attention and your participation, and we look forward to seeing you all very soon. Thank you.